Assalamu alaikum. Dear students, I'm Dr. Zaheer, and today I'm going to discuss approach to headache and headache syndromes. So first things first, headache is a very important problem, and it hits most of the population of the world. The most important thing about a headache syndrome is that you have to differentiate whether it's a primary cause or it has a secondary cause, because in some cases it can be a life and death situation. If you don't differentiate between a primary and secondary kind of headache, you may end up losing a life. Let's have a look at this scenario and try to come up with a diagnosis. 25-year-old secretary has had recurrent headaches for the last 8 years, associated with nausea and nasal stuffiness. Each episode lasts 4 to 6 hours, occurring 3 to 6 times a month. Similar headaches are present in his mother and an elder brother. X-rays of the paranasal sinuses were requested to be done. So let's have a look at our options. The most likely diagnosis would be migraines, sinusitis, recurrent allergic rhinitis, tension type headache. So make up your mind, what do you think, and then we'll discuss what could be the problem here. So first of all, look at the age. He is a young patient, and he has been suffering this problem for quite a while now. And there is history of nasal stuffiness, and it is recurring. It is a recurring 3 to 6 times a month. And he also has got a family history of such disease in the mother and elder brother. And you have been given a clue here that X-ray of the paranasal sinuses have been requested. So we can think of allergic rhinitis, recurrent allergic rhinitis, and it may lead to recurrent type of headaches in such patients. Our next scenario is a 38 years old salesman was brought to the clinic with a 2-day history of headaches, cough, vomiting, and diplopia. So here you are seeing some physical signs. Whenever you see such kind of physical signs like cough or vomiting or diplopia, it should always ring up a bell, and you have to look for a secondary cause. There is history of recurrent headaches in the past, each lasting a few hours. Okay, so on examination he was conscious, temperature was 99.5 degree Fahrenheit. He was uncomfortable in the presence of bright light, and there was mild neck stiffness. So let's have a look at the options. The most likely cause of his complaints would be meningitis, severe respiratory tract infection, encephalitis, migraines. So what do you think? Let's have a look at the scenario again and discuss what could be the reason. So one of the clues is diplopia. It is causing a physical sign here, and the other is the patient is having a fever 99.5 degree Fahrenheit, and the patient is having photophobia as well. Mild neck stiffness. Here is a catch towards the diagnosis. You check for the neck stiffness, it is present, and your diagnosis should be meningitis. So this is how you approach these cases of headache to find out the secondary cause. A 68-year-old male presents with a 1-month history of bifrontal and bitemporal pains associated with fever. So age, look at the age. Now patient is having these kind of headaches along with the fever. He also experiences increasing pain in the jaw while eating. He has lost 3 to 4 kg of weight in the last 4 months. On examination, there is tenderness over the right temporal region. So in this scenario, let's have a look at the options. In the diagnostic considerations, the most likely diagnosis would be temporomandibular joint pain, frontal sinusitis, temporal arthritis, and dental pain. So what could be the reason here? Look at the age of the patient. It's well above 60, and the patient is also having fever, and there is also jaw claudication, the increasing pain in the jaws while eating. The patient is losing weight. This is one thing that should point towards an organic cause of this headache. And there is tenderness over the right temporal region, which means the temporal artery is tender. So the most likely diagnosis should be temporal arteritis here. Similarly, let's go on to our next scenario. A 50-year-old gentleman is brought to the clinic with sudden onset of severe-splitting headaches, starting occipitally associated with nausea, vomiting for the last 1 hour. A similar but less severe headache occurred a month ago. On examination, he was afebrile. There was neck stiffness and photophobia. So let's have a look at the options. A very severe attack of migraine, meningitis, subarachnoid hemorrhage, cervical disc prolapse. So what do you think? Make up your mind and then we'll move on to the scenario. So this gentleman is a relatively older gentleman as compared to our previous case of meningitis. And look at the kind of headache, sudden onset of severe splitting headache. So this severe splitting headache points towards a specific diagnosis. Okay, and the next thing is patient is afebrile. Our last patient was febrile, and that was pointing towards the diagnosis of meningitis. This gentleman is afebrile. There was mild neck stiffness and photophobia. It is very similar to the signs of meningism that we have seen before, but he is afebrile. So here with severe splitting headache, which is severe sudden onset, and sign of meningism in the absence of any fever, the most likely diagnosis should be a subarachnoid hemorrhage. So we can classify headache into two types: primary, which is without an identifiable underlying cause, or secondary with an unidentifiable underlying cause. So here we have to make a right or a wrong decision, and keep in mind, your one wrong decision can put someone's life in jeopardy. Your first responsibility is not to miss a dangerous headache. So let's talk about the dangerous headaches. How would I not miss one? There's only one way: history, history, and history. You have to take a very detailed history, and then you have to make a complete neurological examination of the patient, and ultimately you have to investigate if you are thinking about some kind of organic cause of the headache. So let's discuss some recognizable clinical scenarios indicating dangerous headaches. So these are the recognizable clinical scenarios, which we can call red flags. If any one of these red flags pop up, there should be an alarm going on in your mind that there must be some kind of organic cause of this headache, and you have to investigate for the secondary causes, and you have to treat for the one. Sudden onset headache, if it's an accelerating headache, for example, a patient is having headache before, but now it is accelerating, it is becoming more pronounced. Headache with focal neurologic signs, for example, diplopia. Headache starts after age 50. So old age increases the chances of dangerous headaches. Headache with systemic illness, for example, somewhere in a patient with diabetes, in an immune compromised patient, in a patient with malignancy. New onset headache in a patient with malignancy or immune suppression. Patient with papilledema. So patient with papilledema, always look for a secondary cause. Sudden onset headaches. These headaches can start suddenly. For example, subarachnoid hemorrhage, as we have discussed, there was a sudden onset splitting headache starting from the occipital region, going towards the front, and associated with sign of meningism. Intracerebral hemorrhage, patient might lose consciousness. It is very sudden in onset. It might be associated with headache. Cerebellar hemorrhage, similarly a catastrophic event, a life-threatening event. Pituitary apoplexy, bleeding into an arteriovenous malformation. So these are all sudden onset headaches, and these are very dangerous. These can prove very fatal to life. So in a subarachnoid hemorrhage, the patient typically says that, "Doctor, I am suffering from the worst headache of my life." And when you ask how did it start, the patient typically says that it started in a fraction of a second. We typically call it a thunderclap headache. And the patient will have signs of meningism like neck stiffness. Patient may lose consciousness. Patient have got this photophobia and phonophobia as a result of meningism, and there might be in some cases focal neurological deficits might be present, and we approach this headache with a CT scan brain. In 95% of the cases, CT scan brain shows us the subarachnoid hemorrhage, but 5% cases can be negative, and in these cases we have to do a lumbar puncture, and we examine the cerebrospinal fluid for the presence of xanthochromia. So look at these CT scans. If I can show you. Look here. This is subarachnoid hemorrhage. This is blood in the cisterns, and this is blood in the ventricles, and here you can see the blood in the sulci. So this is a subarachnoid hemorrhage. Intracerebral or intracranial hemorrhage or cerebellar hemorrhage. Usually it is hypertension related, but the etiology can be unknown, especially in a younger patient. Focal neurological deficits are almost always present. CT scan is the best investigation to diagnose an intracranial hemorrhage, but in some cases MRI scans can also help. So see, this is an intracerebral hemorrhage, and this is a CT. This is an MRI of the same hemorrhage, but you can see it is very evident on CT scan of the brain. So this CT scan of the brain plane is the most sensitive investigation to pick up intracerebral, cerebral or cerebellar hemorrhage. So our next red flag is the accelerating headache. Headache has a gradual onset, so the headache is present before and now it is accelerating. Becomes increasingly severe over days to weeks, and the usual suspects are a brain tumor, a subdural hematoma, especially in elderly. Elderly may hit their heads, very trivial trauma to their heads, and they develop subdural hematoma, which keeps on increasing, and it presents as an accelerating headache. Dural venous sinus thrombosis, subacute or chronic meningitis, medication overuse headache. So CT or MRI scan can help to differentiate these kind of headache. For example, brain tumor will be very evident, subdural hematoma will be very evident on a CT scan brain, and dural venous sinus thrombosis will be evident with an MRI brain plane, contrast, and magnetic resonance venogram. Meningitis can be diagnosed with a spinal tap, and for medication overuse headache you need a very clear history. There will be history of medication overuse, and it will guide you towards the right diagnosis. So here you can see the subdural hematoma. There is the convex border and there is the concave border, and it is present subdurally, and this is looking very hyperdense. So hyperdense is acute subdural hematoma, while if it is hypodense, hypodensity will indicate the presence of a chronic subdural hematoma. Dural venous sinus thrombosis, this is a magnetic resonance venogram, and here you can see that this transverse sinus and sigmoid sinus, these are very evident on this left side, while on the right side this transverse sinus is not very evident and sigmoid sinus is absent. So it is indicating the presence of thrombosis, dural venous sinus thrombosis. So headache with focal neurological signs. It means there's a weakness, there are focal there can be focal fits, there can be a cranial nerve damage, or some sensory phenomena can be there. So mass lesions like tumor or abscess can cause it. Sometimes for strokes can be there, vasculitis, encephalitis. These are all the kind of headaches which can present with focal neurological signs. Here you can see a brain abscess on a CT scan, and remember, CT scan brain, if you are suspecting a case of brain abscess, you always order a CT or MRI of the brain along with a contrast, because the contrast enhancement will tell you that extra information that is needed to make the that is needed to clinch the diagnosis. So this is a case of herpes encephalitis. You can see on the MRI there is hyperintensity of this hippocampus, and the whole temporal lobe is illuminating. These are hyper intensely on the right side of the temporal lobe. So here you can see this is an arteriogram, and here you can see the beaded appearance of the vessels. This beaded appearance of the vessels indicate the presence of CNS vasculitis. So headache starts after age 50. This is another red flag sign. Always try to investigate the cases who come after the age of 50 and there is a new onset headache. Keep in mind temporal arteritis. This is very important. There can be some very fatal consequences if this goes untreated. It is almost a medical emergency if this case comes to your clinic, and you need to start the treatment right away. Primary brain tumors, metastatic brain tumors, because incidence of malignancies is higher in older age. So let's talk about this important disease, giant cell temporal arteritis. This is a chronic vasculitis of large and medium-sized vessels. It almost never occurs before the age of 50, and if the patient comes after 50, you should have a very low threshold for suspecting this kind of headache. And incidence rises steadily after 50. New type headache in 2/3 of affected individuals is present. So the pain is located over the temporal areas. The possible symptoms include fever, like in the case that we have discussed previously. Fatigue can be there, weight loss, significant weight loss, jaw claudication. Whenever the patient chews something, there's pain in the jaw, and that is called the jaw claudication. Visual symptoms, particularly transient monocular visual loss and diplopia. So if someone is having this recurrent visual loss, transient recurrent visual loss in one of the eyes, and the patient is older, you have to think of giant cell temporal arteritis. And symptoms of polymyalgia rheumatica. It is kind of a spectrum of giant cell temporal arteritis which presents with body pains. ESR is typically raised. So if the patient has got age more than 50, there's a headache which is predominantly in the temporal areas, and ESR is high, your suspicion for giant cell temporal arteritis should be very high. CRP is raised, and there can be thrombocytosis. So diagnosis is to be established with temporal artery biopsy, and which is the gold standard. So here you can see a very tortuous and prominent temporal artery in this older gentleman. ESR is typically high, C-reactive protein is high, and temporal artery biopsies shows positive findings of vasculitis. Remember, temporal artery biopsy, there are skip lesions. Some portion of the temporal artery is involved, while other portions of the temporal artery are spared. So you always take a longer strip of the temporal artery, because if you take a punch biopsy of a very small region, it might not be affected, and you'll be misguided about the diagnosis. So the management is with steroids, high dose steroids. 60 to 80 milligram per day are given, and once the response starts coming, we gradually reduce the dose to 30-40 milligram daily over 1 month, and it is further reduced within 3 months to 10 to 20 milligram per day. And we check for the response, we monitor the clinical progress. ESR can be monitored, and it can guide us about the disease activity. Further maintenance of 5 to 10 milligram per day with clinical response and ESR monitoring is to be done. Further reductions with strict monitoring. Treatment usually required for 1 to 2 years. So primary brain tumor, here you can see one. This is a primary brain tumor, and metastatic brain tumors can be there, and this can present after the age of 50. So headache with systemic illness. If the patient is having fever or meningism, meningitis, encephalitis, if there are behavioral changes as well, especially if there are fits, systemic infection, collagen vascular disease. So we must keep this in mind. And here you can see this is meningeal enhancement, basilar meningeal enhancement in a patient with meningitis. The patient is given a contrast, and these meninges become enhanced on MRI brain, and this will indicate the presence of intracranial, especially meningeal involvement with infection. If there is a new onset headache in a patient with cancer and immune suppression, there should always be an alarm in the back of your mind that there might be something sinister going on and you have to investigate. It includes meningitis, brain abscess, metastasis. So you can see this patient this gentleman is having bronchogenic carcinoma of the lungs, and there are mets in the brain. So you have to look for a primary cause as well. Meanwhile, you image the brain for presence of metastasis. So here, this is again a case of meningeal enhancement in case of carcinomatosis, in which there are malignant deposits on the meninges. And the last thing is, we never treat a patient with headache without doing a fundoscopy. Fundoscopic examination is of such a paramount importance, because if there is papilledema, there is always a secondary cause. Mass lesion can be present pseudotumor cerebri, also known as idiopathic intracranial hypertension, chronic meningitis, or even acute meningitis can present with papilledema. So always get a fundoscopic examination done, and if there is papilledema, think of a secondary cause. It will clinch the right diagnosis. I've seen cases in which go on undiagnosed for like 2 years, and ultimately when the fundus was examined, there was papilledema, and the presence of papilledema led to the right diagnosis. Like it specifically occurs in idiopathic intracranial hypertension. So this is a picture of the fundus. Here you can see this is the optic disc, and you can appreciate the blurring of the margins of the optic disc. And here this is like grade 4 papilledema, in which you cannot differentiate between the disc and the normal retina. So if we summarize our discussion of the dangerous headaches, although dangerous headaches are not as common as primary or non-serious secondary headaches, a correct diagnosis is a challenge and vital for management. A good history and relevant physical examination is the key. Identification of the patient with a red flag is vital. Change in the character of an already existing headache should not be ignored. When in doubt, seek immediate assistance and/or referral. For example, if you perform a fundoscopic examination and you are not sure of the presence of papilledema, always seek the help from an ophthalmologist, and so on and so forth. So you can involve an oncologist for the presence of malignancy. You can involve the help of an infectious disease specialist for these chronic infections. So